You finish the antibiotics prescribed for your UTI, start to feel better for maybe a couple days, weeks, or even months. And then it comes back, your symptoms. You go back to the doctor, you get another round of antibiotics, same thing happens. Eventually your cultures start coming back negative despite symptoms persisting. Your doctor says, "You're fine, there's no infection." But here's what they don't know. Your infection isn't coming back, it never left. Hi, I'm Alessandra. I've been dealing with UTIs and UTI symptoms for over 10 years. About 6 or 7 years ago, I was diagnosed with interstitial cystitis. I've seen multiple urologists, infectious disease, urogynecologists, and not a single one of them mentioned what I'm about to tell you now. I only started getting real relief this year after finding out my pain, which was no infection, had a real cause. It was an embedded infection this entire time. And I've spent the last few years doing more research on this than I ever wanted to do. So let me break down the top 3 reasons why your UTI isn't coming back, it never left. I just want to preface this video by saying I don't think every single person who experiences bladder pain is dealing with an embedded infection, but if your pain started with a UTI that felt like it never went away, still lingered, or just kept coming back, please keep watching, this video's for you. Reason number 1 is standard culture inaccuracy. The standard urine cultures, the one that doctors use to diagnose whether or not you have a UTI, has its own serious limitations that most patients never hear about. And the reason why starts in 1957. The threshold that your lab uses to determine whether or not you have a urinary tract infection, 100,000 colony-forming units per milliliter, comes from a study by a scientist named Kass. He developed that number by studying a small number of women who had pyelonephritis, which is a kidney infection, not a bladder infection, not a urinary tract infection. And there he drew the line at 100,000 CFU. That threshold was never intended or validated for diagnosing bladder infections. And yet, we still use it to this day over 40 years later. Standard cultures work by putting your urine on a plate and waiting 24 to 48 hours to see what happens. If the bacteria are slow growing, hiding in cells, or lower in count, your culture comes back as no growth and your doctor tells you you're fine despite there being an active infection. On top of that, these cultures are highly biased towards growing E. coli. If you're dealing with another type of bacteria like Enterococcus or Klebsiella, it's even more likely that these cultures are continuing to come back negative for you. And that 100,000 threshold, in 1982, researchers at the University of Washington wanted to test how accurate this really was. They compared regular urine samples, the kind where you go into your doctor's office, pee in a cup, and provide the sample, to samples taken directly from a bladder using a catheter. These samples are far more accurate since they're less likely to contain any contaminants from skin or anything else. They published these findings in the New England Journal of Medicine, and what they found was that the 100,000 cutoff missed half of real infections. Half. That's basically going into a doctor's office, giving your sample when you're symptomatic, and then having a basically coin flip chance of your doctor saying that you have a real infection. When they lowered the bar to a much smaller amount of bacteria, they caught 95% of real infections. And yet, we still use that 100,000 CFU count today. Dipsticks are even worse. Reason number 2 is intracellular bacterial communities. The bacteria are hiding in your bladder cells. E. coli and other UTI-causing bacteria don't just float around in your urine. They can invade the cells lining your bladder, form colonies inside those cells, go dormant, completely invisible to antibiotics and your immune system. These are called intracellular bacterial communities, or IBCs. Think of it like bacteria building a safe house in the lining of your bladder. The antibiotics can't reach them there. When those bladder cells naturally turn over, those bacteria re-emerge, start multiplying, and you have another UTI, but really it was the same bacteria from the same infection. This is why you feel better on antibiotics. They kill the bacteria free-floating in your urine, but symptoms return days or weeks later. The reservoir inside the cells is never touched. A 2021 study published in eLife built a model of the human bladder to test this. They found that antibiotic treatment did not guarantee complete eradication of bacteria within these intracellular communities. In some cases, the bacteria survived and reseeded the infection. I hope at this point in the video, the wheels in your brain are turning and you're starting to second guess all the times that your doctor dismissed your symptoms all because your culture was no growth. Let's move on to the next reason. Reason number 3, biofilms are shielding the bacteria. No, don't do that. Guys, bacteria are smart. They're living inside us and they want to survive. And the way they do this is by forming something called a biofilm. Think of it like a fortress. Bacteria group together and coat themselves in a sticky layer made of proteins and sugars. Once they're inside that layer, they're protected from almost everything. Your immune system, antibiotics, all of it. And the numbers on this are crazy. A review published in the journal Life in 2023 by a team of researchers in Italy decided to look at how biofilms behave specifically in recurring UTIs. Bacteria surviving inside of biofilms can survive antibiotic concentrations up to 1,000 times higher than the bacteria that's free-floating in your urine. So when a doctor gives you the 3 to 7 day course of antibiotics, it does kill the bacteria that's floating around in your urine causing symptoms. But the ones inside the biofilms are barely touched. When you stop the antibiotics, in a matter of days, weeks, or months, bacteria just repopulate and your symptoms come right back. A separate study published in Antimicrobial Resistance and Infection Control confirmed this and took it a step further. They found that biofilms don't just protect the bacteria from antibiotics, they shield the bacteria in your bladder from your own immune system so your body can't even get in and clear the infection on its own. And biofilms aren't unique to UTIs. They are a well-studied and well-known phenomenon. They're present in chronic ear infections, sinus infections, wound infections that are slow to heal, yet no doctor ever brings them up when it comes to urinary tract infections. This is also why a review published in January of 2025 in Antibiotics suggested that pulsed antibiotic therapy be used in treatment for recurring UTIs, meaning strategic repeated courses of antibiotics to actually target these biofilms. And I do want to add another disclaimer, this goes without saying, I don't think anybody should treat their symptoms with long-term antibiotic therapy without knowing what bacteria and susceptibilities they're dealing with. They can have long-term serious side effects associated with them. I know that was a lot of information, but the good news is there is a way to stop your recurring UTIs. The first thing that I advise everyone to do is track your symptoms. Guys, symptoms are so key, like they tell you what's going on in your body. If your UTIs keep returning after antibiotics and seem to be caused by the same triggers like sex, movement, or exercise, this very well could be a major signal that you're dealing with some biofilm involvement or an embedded infection. I spoke a lot about the limitations of standard urine culture testing. The good news is that better testing does exist, and you can ask for it. PCR or DNA-based testing can detect bacteria that standard urine cultures straight up miss. You can ask your doctor to order these, or you can order them yourself. Now, I will say a lot of doctors are hesitant to order PCR tests, or they'll tell you that PCR-based testing isn't accurate, and that's because these tests do have real limitations. I am going to tell you what these limitations are so you can make better, more informed choices in your care and have a more productive conversation with your doctor about these tests. While advanced testing like PCR or next-generation sequencing, NGS, can be incredibly helpful in finding bacteria that standard urine cultures miss, it is true that they can over-detect bacteria. They can pick up dead bacteria that's not clinically significant, or harmless microbes that make up a healthy urinary microbiome. Because of this, I always recommend that PCR testing be combined with diligent symptom tracking. This is why symptom tracking is so key, and you want to work with a provider who will treat you and your symptoms, not just a piece of paper. The goal is to use these tests to find out which bacteria is causing your symptom flares, not to eradicate every single microbe that the test finds. Question short antibiotic courses. If you keep getting 5 to 7 day courses and your UTIs keep returning, it's okay to push back on your provider about this. You can ask for longer targeted based treatment based on the bacteria that they're treating and the susceptibilities that bacteria shows. Don't just accept a diagnosis of interstitial cystitis without the full workup. I am not saying that I think interstitial cystitis is not a valid diagnosis, is not a real disease, because I don't think that. But if your symptoms started with a UTI that felt like it never went away, it very well could be that you're dealing with an embedded infection or some biofilm involvement. I think it's always important to be informed in the full workup you should receive, and remember that I see as a diagnosis of exclusion, meaning other causes should be excluded first: infection, anatomical issues, and many, many more issues. A lot of doctors skip the full workup, and then all of a sudden your doctor says, hey, you have this for the rest of your life, manage with physical therapy. You're not crazy and your pain has a real cause. If your doctor isn't looking deeper, I encourage you to push back on that a little bit, or just find a new provider who will. I hope that you found some of this information helpful to you, and if you did, please like and subscribe, as it genuinely helps this channel out, and I'll include a more comprehensive list of resources and how to get help for an embedded infection in the description below. Thank you. Bye.